thank you, Tony. It's a great honor to be here, and actually I'm looking forward to questions afterward. This is something that we really sort of stumbled into when we began. We essentially went back to our educational program and we said, are we training surgeons in the best manner? And it was a very serious question, and the answer may have been yes, it may have been no, but that's what led us into this effort. So I'd like to go ahead and begin then. I don't think I'm advancing. There we go. Okay. So this is the question that we began with, and we were fortunate enough to be able to come across Tony Gallagher, and it helped us a tremendous amount. We've all been trained surgically for centuries using the apprenticeship model, and perhaps that's the best and perhaps not. And Tony convinced us that there may be a better way, and that is proficiency-based training. And so this was a significant paradigm shift from the way we had done surgical training in the past. And so because this was a complete paradigm shift, Copernicus was the one credited for the change from the Earth being the center of the universe to the sun being the center. So we thought, well, that's a good name. So this became the Copernicus Initiative for the Arthroscopy Association. So what we said to Tony was, we said, well, this is great, but if this is going to be something that we're possibly going to need to adopt and convince our membership and our leadership that we should do, we've got to have some evidence that in point of fact this is better than the way we train now. What we realized is that in order to do that investigation, we needed three tools. First, we needed a metrics tool. We needed to be able to measure, are you better than you in terms of performing a particular procedure? So we had to have some good objective means, and that was the development of metrics for a particular procedure, and we chose to use an arthroscopic Bankart repair as the index procedure. We needed a training tool. We needed to say, do these metrics coupled with our dry model simulator, in point of fact, do they have construct validity? Will they distinguish between experienced and novice operators? And finally, we needed an assessment tool, and since the cadaver is the closest approximation to a live patient, we used that. We did another whole study using the metrics with the cadaver so that we could again prove that this coupling actually was able to discriminate between experienced and novice performance. So this is basically the routine. We had three groups of residents. Group A was traditionally trained the way we normally do. We bring them in, they go ahead and go through a training protocol, and I'll get to that in a second. We needed to make sure that all of these residents were starting from the same point. So each one of them had the opportunity to review a video that I created that went through each of 45 steps. It identified or showed each of 77 errors. So all of these residents were starting from the same position. And then we needed to know that these residents, there wasn't a good group and a bad group, so all of them went through baseline assessments, including visuospatial, perceptual, and psychomotor testing. No differences. The A group actually was slightly better, but not statistically significant. So then the A group then went through and had the opportunity to view lectures. These were given by faculty, indications, contraindications, and case examples. And then they went on to do knot tying practice under clinical faculty guidance, just as we normally do now. They practice as much as they want, as long as they want it. Group B, then once they went through the same lectures and knot tying practice, had the opportunity to work as much as they wanted with the dry model simulator. They could practice every single step of the procedure on the model as many times as they wanted. Group C, however, up in the online video, they had to actually pass a cognitive test that demonstrated they knew the principles in all of the steps that were available. So they actually had to demonstrate they knew the material. Secondly, for knot tying, they actually had to pass knot tying proficiency. They had to have their knots stressed at 15 pounds for 15 seconds. 3 of 5 knots had to pass that proficiency. If they failed, they went back with their instructor, practice more until they could actually get knot proficiency before moving on. Then when they got to the point where they worked on the model, again, they worked as long as they wanted, but then they had 2 tries, brand new model, and they had a faculty reviewer. They did the entire procedure on the model, and they were scored in real time. And they had to meet a benchmark that was previously established with the work that we did before. So there was a clear benchmark, and it was the mean of what the experienced faculty performance was. So that's the benchmark. So they had 2 tries. If they failed on the first try, went back, went with their instructor, tried to work through the problems and where they had deficits, then they got another try. So they had 2 tries to go through and demonstrate proficiency. And so then all of these groups then had the opportunity to do the same. They worked with a cadaver and faculty, the experienced faculty throughout all 3 groups. And then the final assessment was at the end of each group of training, they had a brand new cadaver, they had an assistant who couldn't coach them, and they did an arthroscopic Bankart repair, and the entire procedure was videotaped. And then at the end, so we have each of those each of those faculty has a videotape, and those videotapes were then scored in blinded fashion by a group of 10 raters who had actually been trained, and the inter-rater reliability among this group was 93%. And part of that is because when the metrics are developed, they were tightened up so tight with definitions that all the reviewer had to do was say that event occurred or it did not occur. There was no global rating, there were no assignment, so it was very straightforward. They were trained, and the inter-rater reliability was never a question. In one instance, we had 80%, which was the lowest that we had of any of them. So we had 21 programs across the country represented. So we started out, there were, this is off the screen, oh, it is for me. So 44 residents. The A group were volunteers from a regular resident course, so we only had 14 volunteers. We would have preferred 16, but we had 14. And Group B had 14 residents. Group C had 14 as well. So Group A was traditionally trained. Group B was simulator enhanced. They had the benefit of the simulator, but no metrics. Group C had proficiency-based metrics involved in their teaching. So if you look at Group A, traditional training, but 2 of those Group A patient residents were not able to complete the final procedure, just got so far and just couldn't get any farther. All of the Group B residents actually completed their surgical procedure at the end. Group C then, I guess I better stand over here. So Group C then, several couldn't pass initially the online training, went back, studied more, and everyone eventually was able to pass the cognitive training. Suturing and knot tying, so there was one individual that no matter how much practice they made, they just simply couldn't meet the benchmark for suturing. And then finally on the arthroscopic Bankart repair on the simulator on the model, 6 individuals from that group of 16 failed their first attempt, and so each of them got a second attempt, and 2 actually passed on the second attempt. So there were 4 individuals, one of which was the same that couldn't pass knot tying. Those 4 individuals couldn't meet the proficiency on the model. So this brings us down to 12 out of 16 were able to meet all of those benchmarks along the way. And one of those 16, which was one of the 4, was not able to complete the final Bankart repair. So this is what we found. If we looked at the Bankart steps completed, there was a significant number of steps more that were completed by the C group, the proficiency-based group, and this was statistically significant. If we looked at time taken, it wasn't significantly different, even though the C group actually completed more steps, but it didn't take them longer to do so. The intraoperative errors, this is critical. This is probably one of the most important aspects of it. And these were statistically significant differences. So group C versus group B was 41%, and C versus A was actually up to over 50% reduction in the number of errors that were actually enacted. And then sentinel errors, which are more significant errors, either defined by the fact that it jeopardized the entire procedure if that error occurred, or that potentially led to significant iatrogenic damage. These percentages are quite high, but they did not reach statistical significance because the incidence of sentinel errors was low. So even though the percentages are different. So this is the benchmark, and this was established again with the study using cadavers and the metrics. And so the benchmark was the mean of the experienced group of operators. We intentionally did not call these experts because we had no way of defining what an expert was. So these are people in practice who are doing the procedures on a routine basis, and they happen to be faculty at our courses. So they had to complete a 3-anchor Bankart repair. They could have no more than 3 errors and no more than 1 sentinel error to pass that, to meet that benchmark. So this is the outcome. Group A, this is our traditionally trained group of residents. It's the way we train today, the way we have for many, many years. Just under 30% of those residents were able to actually meet that final benchmark. Group B, 35%. So what you can see is that in this study, at least, the improvement was relatively modest. So what we drew from that is it's not simply the simulator and providing the simulator, because you can practice and practice on the simulator, and that does not necessarily imply that you're going to get transfer of training. And so in some of our literature, what it has shown is that patients or residents who work on the simulator a lot become much better on the simulator, but that doesn't necessarily transfer to the OR because we have no metrics linked to that simulator that actually affect the procedure. So the question we asked at the outset was, is there a better way to train surgeons? And I think this gives us some idea. If you look at the entire C group, regardless of whether they met all of the benchmarks or not, they simply were randomized to the C group and went through proficiency-based training. They had proximate feedback. They had very deliberate practice where they practiced according to the steps and the metrics that were already identified. Simply allocating to the C group meant that you had a 68% chance of getting to that final benchmark for the procedure. And in the C proficiency group, where they met each of those benchmarks along the way, 75% of those residents actually hit the benchmark in their final procedure. So if we just look at a logistic regression analysis, and this probably was staggering for me, and maybe it is for some of you. If you say Group A is the reference, that's the way we've traditionally trained in the past. Group B, fairly modest at 1.4 times likelihood of achieving that benchmark. If you were just in the C group, again, didn't have to meet all of those benchmarks, over 5 times more likely to hit the final benchmark simply going through that metric-based, focused pathway of training. And if you were in the C proficiency group where you actually met all of those benchmarks along the way, and in point of fact, ours was condensed to a weekend, but proficiency-based training essentially means that you don't progress until you meet those benchmarks. So this group of C residents that didn't meet all the benchmarks, we felt that they had put a lot into it. We wanted to keep training them, but in reality, they would not have been allowed to go on and even go to the final cadaver assessment until they had met the benchmarks along the way. So fairly staggering differences. So perhaps, if we put the groups on a learning curve, it might look something like this. That the group B had the opportunity to work with the simulator but they didn't necessarily have the key components that they were working on. So what are the implications? I think we have to expect that fewer errors is probably going to lead to less patient morbidity, fewer complications, cost is probably going to be less, and likely better outcomes. Simulators without the use of the proficiency metrics may not necessarily be as effective. The pathway itself, and this was group C minus, and the total group where they didn't actually even meet all the proficiencies, but simply going through a different training paradigm were dramatically more likely to hit that final pathway. And then finally, there's so much evidence that proficiency-based training is better than the apprenticeship model that, at least philosophically, it's going to be very, very hard to defend continuing to train in the way we have in the past. So I'm going to sort of run through a couple of issues. Harnessing simulation, I think probably a few aspects. Without being coupled to metrics, and this is not my quote, but the quote has been made, may not be much more effective than an expensive video game. And part of the problem is that we maybe have the cart before the horse. It's absolutely essential that we define the procedural metrics and then say what level, what sophistication of the simulator is necessary to actually train that particular skill. And then we can actually build those into the simulator rather than building the simulator and then say, okay, what do we need to try to simulate here? It's the cart before the horse. And Einstein said, if we have complex problems, then the solution to those needs to be as simple as possible and no simpler. And so the analogy is the simulator needs to be as simple as possible and no simpler to train a specific task. So for arthroscopic knot tying, a $25 knot tying board is much more effective than trying to capture that on a VR simulator. A simulator has to provide synthetic experience. As we know, surgeons who have higher volumes, who do more surgery, tend to have better results. They have better outcomes, they have fewer complications, and their patients tend to do better. The problem is that most people in training are in this neck of the woods, perhaps when they come out of training, and then they have to use experience with patients to actually climb their way up this. And so if you practice with a simulator without the metrics, maybe you march along this way, but what you're trying to do is you're trying to simulate an operative experience. And the closer you do that, then that builds synthetic experience, which actually duplicates the real situation in terms of an operative case and allows you to gain experience. So what we'd like to see is residents and individuals, and even those who have been out in practice who are adopting a new procedure, we'd like to see them get way up the learning curve before they actually start to work with patients. So Hippocrates, inconsequential errors, that gives us the opportunity to do no harm. So what we'd like to do is acquire those skills without the downside of the impact on patients. With proximate informative feedback, at the time we make the mistake, what's the error, why did you make it, how do you correct it, and that gives the trainee an opportunity to make those adjustments and move on. Those metrics provide for deliberate practice. So it's not just practice, 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 it's practice the right thing, correct the wrong error, correct the error, and improve the technique that's actually very clearly outlined in the steps and the error metrics that have been worked out previously. So a simulator, again, I think helps us provide the benchmark. It not only does it give the trainee a target, this is what I'm aiming at, these are the steps and errors, but it gives them an intermediate assessment. It was hugely beneficial for those folks that went through and failed their first attempt at the simulator to pass and do the arthroscopic Bankart repair. Their instructor, their rater, and they all sat down and said, all right, here's your score sheet, these are your deficiencies, this is why you didn't meet the benchmark, Now we're going to practice on those particular deficiencies, and they came back and then had the opportunity to correct those in a much more practical and sensible way. So I'll wander through a few brief comments to end on how this might affect the development of medical devices. I wonder if I scooted. So the first of all, I think it provides an assessment template as to, does the particular technology address the need that has been identified in terms of why this new device is necessary, how can it help us, etc. I think it gives us an assessment of whether it meets those needs. Could there be a more effective device? Once you define those metrics and say these are the issues and the specific problems that this needs to address, the metrics allow you to assess whether there might be a more effective technology. Assisting in determining how consistently the application of a device is. If there's a new device out there and in the best hands, that device is still only able to get us to that goal point 75% of the time, we need to know that early on in the process rather than say, wow, this works 75% of the time. Let's invest a bunch of energy and effort into getting it there because look how good it works 75% of the time. So I think these metrics can help us there. It defines the objective for the trainee in terms of the required skills. And so again, the trainee is not necessarily guessing, and the principles that are involved are very, very clear. And it ensures that a practitioner is proficient. So if you have a great technology and you don't necessarily have a great training program to use that technology, perhaps that technology fails 20% of the time. Well, is it the surgeon? Is it the inferior quality of the training? Or is, in point of fact, the device not necessarily up to the consistency standards that you'd like to see? So I think it can be of value there as well. So I think the challenge is not so much to believe that proficiency-based progression training is better. It really is to roll up our sleeves and do the difficult work of saying, clearly this is better. Now, how do we start getting this into our training curriculum? So I want to end by acknowledging Tony Gallagher. Quite honestly, had we not been fortuitous enough to meet up with Tony and have him guide us through this process, we would have been off in Likert scales, and we would have had very little chance to come up with the information that we did. But Tony is a master and knows this proficiency-based training principles and information, and it was tremendous help to us to have him guide us along the way in terms of doing these studies. So over the 5 or 6 years I've known Tony, not only has he been a great colleague and mentor, but I'm proud to call him my friend, and it really was a wonderful association. So thank you very much. Questions?
We're a bit tight, the check's in the post. With time probably for a couple of questions. Yes.
Did you measure the time that Group B and C both spent on the simulator? Is there a significant difference, or is it just the focus of the student, of the trainee, that focuses on specific metrics that have to be met?
We didn't measure that, but I would tell you, I think that the C group probably spent a little more time on the simulator, but that wasn't, I don't think, the issue. The issue is the B residents could have, they could spend as much time as they wanted, and without necessarily tying the time on the simulator specifically to those metrics, we could have given them 2 extra days on the simulator and they'd have just continued to do things the way they did the first 2 hours, and it wouldn't have been very helpful. So we didn't measure that. If we did, I think the C group would be longer, partly because they were focused on, I have to do this step according to this metric, and so they took extra time, but I don't think it was simply a time factor, because that wasn't restricted.
Stefan?
Thanks a lot. Very nice talk. Another question. Could you measure it 1 year after the training and see how much better they remembered?
Yeah. I think degradation of training would be an important thing to do, and we don't have that designed or planned. Really, the holy grail is to take these similar groups of residents, but people in practice that are comparable 3 to 5 years out in practice, trained 3 different ways, follow their patients of instability surgery, Bankart repair, and at 2 years look at the results of the outcomes of those particular patients. I mean, I think that would really be the holy grail.
Thank you. Rick?